So objectives, identify objective signs seen during the pediatric sleep studies, understand the role of sleep technologies during the overnight polysomnography. So why hearing disorder matter? Many pediatric sleep disorders are under-recognized because they occur late at night. Parents may report vague symptoms like restless sleep or strange behaviors. Sleep study with video helps differentiate parasomnias, epileptic events, movement disorders, and respiratory-related phenomena. So understand the role of the sleep technologies during the overnight polysomnography is very essential. So again, as I said, it's why hearing disorder matter. Recognize hearing pediatric sleep disorders. Identify objective signs seen during pediatric sleep studies, understand the role of sleep technologies during the overnight polysomnography. Okay, as I said, events often occur after parents are asleep. Symptoms may be misinterpreted as behavioral issues. Overlap between neurologic and sleep disorders. So overnight sleep study with the video is crucial for the differentiation. So parasomnias, we can say there are non-REM parasomnias, as the name arises from the slow wave sleep, typically first third of the night, and the REM-related parasomnias, which obviously occurs during the REM sleep. So non-REM parasomnias, first we can say confusional arousals, sleepwalking, or sleep terrors. Confusional arousals. What are the things we can see? Confusion after partial awakening, disorientation, slow responses, minimal movement, little or no memory afterwards. So when we see something like there's an arousal and kid is not sleeping, we need to go as a technologist. We need to go inside the room and see. Try to talk to them whether they are aware of why they are waking or whether they remember what happened. All those things we can ask. And walking or complex behaviors during the sleep. Blank stare, sometimes they don't walk but they just stare. Difficult to awaken. It's very difficult for those kids to be awakened. Possible injury risk of, obviously they might fall or something. And sleep terrors or night terrors. Sudden screaming or intense fear, rapid heart rate and sweating, appears terrified, usually no memory after the episode. So clinical behaviors of non-REM parasomnias. So sudden arousal from the deep sleep. They're sleeping in a deep sleep. In delta waves we can see, but sudden arousal we see. Sitting up abruptly in bed, confused or disoriented behaviors, crying, screaming or shouting, sleepwalking or wandering, thrashing, kicking or defensive movements they show, and blank stare or unresponsiveness to verbal cues. And autonomic activation we can see like tachycardia or rapid breathing or sweating. So here is one of the video that I got it from our study. Try to play that. So the kid is sleeping nicely. You can see in the PhD study, EEG, like very delta wave sleep. It's sleeping. So sudden abrupt arousal and then wake. This is how the kid behaves. And then they go back to sleep. So this is one of the episodes that we found the kid is crying like a robot cop and crying. And PhD or physiologic finding, abrupt arousal from the slow wave sleep, high amplitude delta activity preceding the event, mixed EEG pattern showing incomplete awakening, increased muscle tone on EMG, sudden movements artifact across all the channels, tachycardia we can see on the ECG channel, and possible increased respiratory rate without epileptiform activity. And you can see the sweat artifact as well because they sweat. Again, this is the same slide. Like for the finding, I can tell you. See it? You can see the increased sleep and then sudden arousal from the increased sleep to wake. And you see the EMG is very high here, and you see the leg movements and all the channels artifact you see here. And when you see the heart rate, it goes up here, like, it goes very high. And when you see the respiratory rate also, it goes high during the day. So this is the mixed EEG pattern. You see the F1, F3 and F4 show you the delta waves, whereas O1 shows the alpha waves. So this is a mixed EEG pattern you see. And this is one of the things from the sleepwalking. All the time, delta sleep, and then patient is moving. So video monitor finding, what we can see in the video monitor findings, like purposeful but inappropriate behaviors, attempt to leave the bed or room, non-responsiveness during the episode, little or no recall after awakening that we need to go inside, and when we try to talk to them, we can find out that. So important differential observation, epileptic activity, possible nocturnal seizure can happen. So that is one of the differential observation. REM sleep behavior disorder, and obstructive respiratory event triggering arousals and periodic limb movements. The next parasomnia, we go for the REM-related parasomnias, nightmare disorders, REM sleep behaviors disorder, rare in children but can occur in children with neurologic conditions, and sleep paralysis. So nightmare disorder typically occurs during the second half of the night, associated with REM sleep, frightening vivid dreams, child wakes fully alert, usually remembers the dream, difficulty returning to sleep. So these are the different, like their child is fully alert and difficult to returning to sleep. So this is different from the non-REM parasomnia. So PEC finding of nightmare, normal REM sleep, muscles atonia. It's muscle normal REM sleep you see, an abrupt awakening from REM sleep, increased heart rate or breathing during the nightmare episode, no significant abnormal motor activity, no complex dreams, enactment behaviors. So REM sleep behavior disorder, acting out dreams, punching, kicking, talking, or yelling during the sleep, dreams, enactment behaviors happen, and risk of injuries. PhD finding of REM sleep behavior disorders. REM sleep without atonia, we will see, and increased chin EMG tone during the REM sleep, excessive phasic muscles activity in limb EMG channels, vocalization or complex motor behaviors during the REM sleep, dream enactment behaviors captured on video. So this is a REM sleep without atonia. You can see the EMG chin activity, and as well as in the limb channels also you see some activities. Sleep paralysis. Sleep paralysis occurs when brain wakes up from the REM sleep, but body remains temporarily paralyzed. Common in adolescents, temporarily inability to move or speak when falling asleep or waking. Awareness preserved, so they are aware of it, may include hallucination or fear. PhD finding of sleep paralysis. Typical PhD finding can include sleep onset REM periods, so REM periods, but sometimes fragmented REM sleep, that is more common. That's what whenever from the wake from the REM sleep and then go back to sleep REM and again so that you get the paralysis. And persistent of REM atonia into wakefulness. Normal EEG awareness during the inability to move, no epileptic activity. What sleep technologists observe? During the polysomnography, technologists may see REM sleep with abnormal movements, vocalization during REM, loss of chin EMG atonia in REM behavioral disorders, abrupt awakening after nightmares. So here the difference between REM and non-REM parasomnias. So REM parasomnias obviously occurs during the REM sleep, and non-REM parasomnias occurs entry deep sleep. Time of the night, REM happens second half of the night, but non-REM parasomnias first third of the night. Dream recall in REM is very common, but non-REM no or rare. Awareness after event, alert on awakening in REM parasomnia, but non-REM confused or disoriented. Examples, right? Going through nightmares and REM behavioral disorders and sleepwalking, sleep terrors. The next one is periodic limb movement disorders. The characteristic, repetitive stereotype limb movements, 0.5 to 10 seconds in duration, 5 to 9 second interval. The first start of the first movement to the start of the second movement, at least 5 seconds or maximum 90-second interval should be there. And PLMA index is greater than or equal to 5 per hour, abnormal in children. So what the sleep technologists observe during the night? So repetitive leg jerks, movements predominantly in non-REM sleep, EEG arousals associated with limb movements, sleep fragmentation, and associated tachycardia following the movements. So this is one of the TLMDs that we found. So you can see all the things like they meet the criteria, like more than 5 seconds and less than 10 seconds in duration, and interval is more than 5 and less than 90 seconds. And you can see some are associated with arousal, but not every moment. And when you see the heart rate here, it rises here, like increased heart rate with the, usually we see the sinus arrhythmia, but here you can see still the heart rate goes up here with all the movements. This is the limb movement in wake period. So clinical significance of PLMD. In children, PLMD may be associated with hyperactivity or ADHD-like behaviors, poor school performance, behavioral dysregulations, mood disturbance, restless sleep reported by parents. Clinical significance. PLMD commonly coexists with restless leg syndrome, obstructive sleep apnea, iron deficiency, narcolepsy, chronic kidney disease, neurologic disorders. The other one is central sleep apnea. So PHC finding can be absence of airflow, absence of respiratory effort, but it's little different from the adult in children, like greater than or equal 20 seconds or greater than equal to breath with desaturation or arousal, we can consider that as a central sleep apnea, may cluster during the REM sleep. This is the central sleep apnea. So here is one of the cluster central sleep apnea, in the REM sleep. And there are some central forces also that is common in children, but if it is more than, but it's better to document that. And periodic breathing also we notice here. Causes of central apnea in children: prematurity, hearing malformation, brainstem lesions, neuromuscular disorders, post-surgical states, or idiopathic. What sleep technologies observed? Central apnea shows no thoracoabdominal effort or bells. In infants, short central pauses may be physiologic. However, recurrent events with desaturation or arousals are pathologic. Carefully distinguish true central events from artifact. Nocturnal seizures versus parasomnias. Diagnostic challenges. Both may present with abnormal movements. Both may occur during non-REM sleep. Video with the sleep study correlations essential. Seizures versus parasomnia comparison. So sleep state. Nocturnal seizures can happen any stage, often N1, N2, but non-REM parasomnias increase low wave sleep. And timing anytime overnight. This is first third of the night non-REM parasomnias. Onset like nocturnal seizures sudden. Non-REM parasomnia confused arousal. Nocturnal seizures is very brief period, less than 2 minutes, but non-REM parasomnias can occur long episodes. Behaviors like nocturnal, this is important, like stereotype repetitive movements you can see, but in non-REM parasomnias, complex behaviors. Responsiveness, unresponsive in nocturnal, but in non-REM parasomnias, partial responsiveness will be there. Recall, usually nocturnal seizures, usually amnesia, but non-REM parasomnias, little or no recall. EEG, you will see in nocturnal seizures, epileptiform activity, possible spiky wave, sometimes you see, but in non-REM parasomnias, no epileptiform activities. Autonomic signs sometimes present in nocturnal seizures, but in non-REM parasomnias, very common. Post-ictal confusion will be there in the nocturnal seizures, rapid return to sleep in non-REM parasomnias. This is the spiky wave. Pattern you see. Role of the sleep technologies: continuous overnight vigilance, recognition of abnormal motor patterns, ensuring EEG signal quality, which is challenging in kids but very important. Event marking and documentation, communication with the physician. This is one of the clinical case example. Patient 7-year-old male, referral reason, behavioral concern, inattention, poor school performance. History shows previously labeled as possible attention deficit hyperactivity disorder, restless sleep parents report, no witness apneas, normal BMI, mild snoring described as quiet, no significant medical history, no enlarged tonsils or pre-exam. Sleep architecture shows prolonged sleep latency, increased N1 sleep, reduced REM percentage for the age, frequent spontaneous and respiratory-related arousals, sleep fragmentation index elevated. So the teaching point here, children often present with sleep fragmentation rather than dramatic oxygen desaturation. EEG or arousal finding, brief 3 to 5 second cortical arousals, increased cyclic alternative pattern, REM instability, no epileptiform discharges. Technologist work here. Many pediatric respiratory events terminate in subtle EEG shift without large desaturations. Respiratory channel finding, Airflow nasal pressure transducer shows flat in inspiratory waveform, prolonged inspiratory phases, a flow limitation without greater than 3% of desaturations or arousals. So we cannot score them as a hypopnea, but respiratory effort belt, increasing paradoxical breathing, progressive rise in effort prior to arousals. Pulse oximetry shows baseline 97 to 98%, rare drops to 94 to 95%, no classic repetitive desaturation pattern. Capnography that entitled CO2 shows gradual rise during the REM, sustained values 50 to 53 mercury for greater than 25% of the total sleep time. So interpretation that this pattern is consistent with pediatric obstructive hyperventilation, flow limited breathing with arousals, early obstructive sleep disordered breathing, not classic adult style obstructive sleep apnea. Final interpretation, diagnosis, pediatric obstructive sleep apnea with hyperventilation pattern, not obvious clinically, would likely have been missed without careful technologies, observation, and CO2 monitoring. So the clinical case 2, age 9-year-old female, referral reason nocturnal seizures, history 3 to 4 episodes per week, occurs within first 2 hours of sleep, sudden sitting up, screaming, thrashing, unresponsiveness to parents, duration 1 to 3 minutes, no recall in morning, normal daytime EEG, started on anti-seizure medication with no improvement. What the technologies observed overnight. Timing, events occur 75 minutes after the sleep onset, that is first third of the night. Emerging from M3 slow wave sleep, sudden abrupt arousal, loud scream, tachycardia, heart rate rises from 78 to 130, eyes open but glassy stare, non-purposeful limb thrashing, no focal motor pattern, no cyanosis. Child settles spontaneously after 90 seconds. It is seizure or the non-REM parasomnia. And EEG finding shows high amplitude delta activity consistent with M3 sleep, abrupt transition to mixed frequency activity, diffuse movement artifact, no evolving rhythmic pattern, no focal spike and wave discharges, no post-ictal suppression. Respiratory channels, stable airflow, no apnea preceding event, normal oxygen saturation, no CO2 retention. Most likely diagnosis, sleep terror. Key features suggesting parasomnias, events arises from the deep non-REM sleep, and no epileptic from discharge before, during, or after, no stereotype motor progressions, no post-ictal slowing, prominent autonomic activation like tachycardia and sweating, confusional state without recall. Take-home messages. Many pediatric sleep disorders are clinically under-recognized. PhD with video is essential for accurate diagnosis. PLMT, central apnea, and parasomnia affect neurodevelopment. Differentiating seizures from parasomnia is critical. Technology's expertise directly impact diagnosis. Thank you.